Hi, I'm Katie Lally with the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health, and I'm here with HIV.gov at CROI 2024. I am feeling very fortunate to be joined by Dr. Deborah Persaud of Johns Hopkins University School of Medicine. Debbie, thank you for joining me.
No, thank you for inviting me
Well,
to present our results.
Of course. And so before we even get into them, I just want to congratulate you on the study team and the participants on the results that you presented today. We'd love to hear you telling us a little bit about the study. Tell us, what are the results of Impact P1115 that you presented today?
So our main finding, which is really very, very exciting, is the finding of 4, not 1, not 2 or 3, but 4 cases of what's called ART-free remission. Now, what do we mean by that? We mean that kids can, in this study, monitored in a very close way, were able to go off their antiretroviral treatment after receiving this therapy at a very young age, in the newborn period. Were able to go off therapy and stay without the virus returning for 48 weeks or more. Now, we had 6 children from the parent trial who became eligible. What we mean is met our criteria to be able to undergo this analytic treatment interruption. And 4 of the 6 children met our clinical trial's definition of what ART-free remission would be for this trial, which is being off your antiretroviral drugs for 48 weeks and following them to see if the virus would come back. We continue to follow 3 of the 4 children who made it to the remission stage of the study. 1 child rebounded at 80 weeks or 20 months, so still beyond the 48 weeks period, but rebounded at 80 weeks after being off antiretroviral treatment. So what does this tell us? We've learned from this study, which was actually built on our first case report over 10 years ago in 2013. Can't believe it's been that long, on the Mississippi baby, who we identified as having ART-free remission. And we thought that outcome, which you never see in HIV infection, being off therapy for 27 months without the virus coming back, we thought what was key in that child was that she was treated very early. What we mean by very early, Katie, is 30 hours of age for the Mississippi baby. Mm-hmm. In the Impact P1115 trial, these are babies who were born with HIV, so in other words, got infected while in utero, as we would call this, in utero HIV, and they were started on a triple drug regimen, really, or an old regimen, which is what we have a lot of expert and experience in using these drugs in infants. Received this within 48 hours of life, had confirmed infection, and the treatment regimen was fairly intensive. It was a 3-drug regimen for the first 2 weeks. When the child got to about 2 to 4 weeks of age, because there's a certain age window that lopinavir, ritonavir can be used in children, they got lopinavir added, bringing them to a 4-drug regimen.
Wow.
And then to a 3-drug regimen when they had reached suppression for at least 2 time points after starting the treatment. So the main trial actually started out with 54 infants. So I want to, set the big picture here. Yeah. It's not, we had 6 infants, but we started out with 54 infants starting this very early treatment. And only 6 made it to this point to stop antiretroviral treatment. Now, what does that mean to get to that point? They had to really be suppressed. Mm-hmm. They had first get to a certain level at 6 months of age, which is what we call less than 200 copies of plasma viral load, and then stay suppressed after 48 weeks for the duration of that study period with absolutely no detectable HIV RNA in the blood. Mm-hmm. And before we stop treatment, obviously, we revisit with the family. They have to reconsent to enter into this phase of the study of stopping treatment. All 6 infants who met that criteria of suppression, the parents agreed to participate. So in the treatment interruption. Mm-hmm. So we didn't have any parents not agreeing to participate because they were very invested in the potential outcome of the study and what it means for kids globally. And so 4 of the 6 children achieved the remission outcomes. I do want to say that two of the 2 rebounded and they developed acute retroviral syndrome.
Can you tell us what that means?
Yeah, so what that means, so in adults, it's very common for an adult with acute HIV, so just acquiring HIV infection, develop symptoms of fever, sore throat, kind of flu-like symptoms or symptoms of mono, but it's not commonly seen in children. So that made us kind of think through, the analytic treatment interruption step or the treatment pause in these children. I want to emphasize that the symptoms were mild. There were some laboratory abnormalities that were moderately abnormal, but those all returned to normal in a very short time. Importantly, all of the 3 kids who rebounded, we were able to resuppress their virus to undetectable or non-detectable levels with restart of antiretroviral treatment.
So those are mind-blowing results.
Yes.
And so you're saying that of the 4 children that achieved remission, 3 continue to be in remission, right? And so where does the research go from here?
Yeah.
What are you doing now to figure out how this happened and figure out what to do next? What's sort of on the horizon there?
Yeah, so I think first what the research told us, so we had an N of 1 in 2013. We had an idea of how this might have happened. We didn't know if the Mississippi baby was a one-off and something very unusual. I think in 2024, so 11 years later, we actually show that this is a biologically plausible way of interrupting the reservoirs that really prevent people living with HIV, children and adults, from ever going off their antiretroviral treatment. Where do we go from here? I think obviously it's important for us to think through that we started out with 54 infants and we only ended up with 6 being suppressed. And I think that small number highlights we need to do better for getting HIV suppressed and staying suppressed in children. So our first priority is to get more kids suppressed. So more 54 to 6, maybe 54 to 40 or 54 to 50. That's a top priority. And so how can we do that? When we developed this clinical trial in 2014, the only drugs that were available for treating newborns, in fact, no one treated newborns. And this trial, identified the safest dose to use nevirapine in this age group. And so we are now fortunate that we have integrase inhibitors, data on how to dose raltegravir in newborns. So the study has advanced to now using integrase inhibitors, more potent. Also broadly neutralizing antibodies, right? They're antivirals, but they're immunotherapeutics that could also maybe stimulate the immune system in these children that could potentially have what's called a vaccinal effect, maybe inducing even an immune response at the same time. So I think that we have to think about a roadmap here for 10 years, not, it took us 10 years to get here. So we need to think about the next 10 years. I'm very optimistic, at this meeting, the focus on HIV vaccine development, how to develop better vaccines by targeting B cells in a better way. And I'm very hopeful with us identifying very early treatment really curtails or restricts the size of the reservoir, that if we can identify vaccines or any immune-based approach to stimulate the immune responses in these children so that if the virus pops up, their immune system can take care of it. So I think our 10-year plan is really going in that direction. Now we know how to get to small reservoirs. We need more kids to be suppressed, but then we need to figure out how to control on top of that.
Yeah. And so the research that led to this point was very complex, and the research that will follow it is probably equally or more complex. But is there a take-home message for service providers now? It's not to start interrupting treatment in children, right? But what is the main takeaway today from this study for service providers?
So I think it's important to emphasize the burden of pediatric HIV infection is in sub-Saharan Africa, lower resource settings where access to testing is not readily available. So it's on us with this finding to really push implementation science towards having newborns and infants having access to point-of-care testing so they can be diagnosed early and put on treatment.
Yeah.
And even if that's not for remission or cure, we know that treatment of children and early treatment and very early treatment is life-saving. And so I think what your question in terms of stopping treatment, we have to stop treatment to determine whether someone's in remission. And so I do want to caution care providers out there. We know that when you treat children early, meaning 2 to 3 months of age, compared to very early, which is 48 hours of life, we know these kids can become antibody negative and have no detectable DNA in their peripheral blood. So if you do a test, an antibody test and a DNA test on your adolescent or older child, and they test negative, please don't take them off therapy. We know those kids will rebound. This is very early treatment. It's not early treatment. And this study was done in a very, very carefully, closely monitored way. Very intensive sampling, blood sampling, checking for viral loads with specialized tests that we can get results in an hour and a half. So we will get there someday when it can be generalizable, but not 2024, maybe 2030 or beyond.
Yeah, well, we're going to be talking about and learning from this study for a long time.
Yeah.
Congratulations again, Debbie, and
Yeah.
thanks to you and the study team and the communities in the
Yeah.
countries where this study's been taking place, and of course, the parents and the children
Yeah.
who participated. We'll let you go.
Yeah.
She's been the woman of the day here at CROI.
Yeah.
Thank you so much for watching. If this is your first time joining us, be sure to check out our coverage from the previous days of CROI. We appreciate you being here with us. Take care.
Yeah, no, thank you, Katie.
Of course.